different things. All right, so let's talk about the necrotizing periodontal diseases. We used to call them ANUG and ANUP, and then they changed in 1999. They changed and they changed yet again. Necrotizing periodontal diseases in 1999. They took the acute out of necrotizing diseases because there's no acute. So it includes necrotizing ulcerative gingivitis and necrotizing ulcerative periodontitis. So we call it NUG and NUP. And they're separate because NUG is gingivitis and NUP with periodontitis. And they're seen in different people, okay, different systemic situations. So the acute was eliminated because of just as a clinical description. So we're not using it now as a term, but you'll see some of us old people call it ANUG for acute necrotizing ulcerative gingivitis. Now, NUG was first used is in World War I with the soldiers in the trenches. It was affecting the younger population, and they were having some severe outbreaks of very painful gingivitis. Now look at the bugs that are associated with it's trench mouth, Vincent's disease, or necrotizing gingivitis today. They've even taken the new classification, has taken the ulcerative out. P intermedia, here we go again with that P intermedia. Spirochetes. Necrotizing gingivitis is a spirochete-driven infection. So when you see or hear spirochetes, think of necrotizing gingivitis, the Treponema species. Spirochetes invade deep into the connective tissue. There are other etiological factors for necrotizing gingivitis: stress, immune suppression, smoking, malnutrition, pre-existing gingivitis, tissue trauma, okay, which is opening up a lesion, as well as immunosuppression, decreased PMN function. So right now, this is describing a lot of college students, 18 to 30, under stress. Their diet is gone, they're not eating well. But there are some clinical features for necrotizing gingivitis, and you need to know this. One of them is a punched out papilla. The tip of the interdental papilla is cratered. Okay, it's punched out, it's gone. There's gingival bleeding, oftentimes spontaneous. This is angry tissue, my friends. Patients can sometimes wake up with blood on their pillow. It's very painful. They aren't brushing because it hurts. They aren't brushing because it bleeds, and that's just aggravating the entire situation. There is sometimes a pseudomembrane that can be wiped off. It's just dead tissue, but some textbooks will say a pseudomembrane is always present. Our textbook is saying it's not always present, so pseudomembrane may be present, but that's one of the hallmarks. Punched out papilla, pain, pseudomembrane, but it's gingivitis, so there's no bone loss or attachment loss. It's only affecting the gingiva. Necrotizing gingivitis and necrotizing periodontitis. All right, the classifications are still the same, but the new classification is they just took the ulcerative out of it. And you want to know the difference, what bugs are involved. Necrotizing gingivitis, you've got your P intermedia, and your fusobacterium, you've got your spirochetes. Then there's something called necrotizing periodontitis, or NUP, necrotizing ulcerative periodontitis, that you usually only see in HIV these days, HIV infected patients. your P. gingivalis, P. intermedia, Candida. There's an underlying yeast infection going on. The necrotizing periodontitis is associated with immunodeficiency. Necrotizing gingivitis is your typical, think of your typical teenage college student, young adult. Now, the book is saying this is NUG. Interproximal necrosis, bleeding, pain. Is this NUG to you or NUP?
That looks like there's some definite perio involvement.
Definite, definite. Oh my gosh, that bone level should be right here, 2 to 3 millimeters below the CEJ. I mean, yeah, but this is what the book has for you. So this is definitely not NUG. Differential diagnosis. You want to rule out, if a patient comes with what you think is NUG, you want to rule out certain herpetic infections. So you want to rule out primary herpetic gingivostomatosis. You want to rule out linear gingival erythema, which you see in HIV patients, recurrent aphthous ulcers, desquamative gingivitis, which is gingivitis that just peels for no reason. You just touch it and it peels. Acute leukemia and infectious mononucleosis. So you can see that there's other things that can look like NUG. But in order for it to be NUG, this is a test question, you have to have 3 criteria. Punched out papilla, pain, and spontaneous bleeding. You have to have those 3. Punched out papilla, pain, spontaneous bleeding. Primary herpetic gingivostomatosis. Stomatitis, excuse me. You can see the biofilm, just the cottage cheese here, but everything looks swollen. So this would be diffuse erythema versus papillary or marginal, and diffuse just kind of, you can just see it all over. Primary herpetic gingivostomatitis. You can see little sores also sometimes. Now, this primary herpetic gingivostomatitis usually occurs in the younger age. What age do you think this patient is? We don't know, but the canines aren't in, premolar. So that's something I always look at too. So what do you need for a diagnosis to rule out? You need, okay, other things. Do they have lymphadenopathy? Not always. Lymph nodes, are they inflamed? Do they have a fever? Not always. Fetid or oral odor. Oh my gosh, these are patients that just, you smell them coming in before you see them coming in, just like some Perio breath, we classify them. Okay, but there is a distinct odor of death in their mouth. Not always. So does the dentist prescribe an antibiotic or not? It all depends if they have a fever and lymphadenopathy. Some dentists will automatically put them on a broad spectrum. Pseudomembrane may be evident. Pseudomembrane, does it wipe off? It can be white to gray. Recurrent aphthous ulcers. This is not NUG. Acute leukemia. How would you differentiate that from anything else? Again, the patient isn't responding to normal treatment, so you have to start looking inside. You've taken them through your periodontal therapy, their plaque control is good, their oral hygiene is good, their diet is good, you send send them out to get some blood work taken. Send them to their primary care physician. Linear gingival erythema. Linear gingival erythema. Now, this is associated with HIV. But doesn't it look like your garden variety inflammation? Hard to tell. I don't want you freaking out. If a patient comes in like this, you go, oh my God, they've got AIDS. They don't, all right? But you want to, again, do your OHE with them. And then if this is still present, even though the biofilm isn't there, you have to start thinking about what other things are going on. Linear gingival erythema. Okay, this is a reaction that isn't biofilm based. So you're going to see the patient. They oftentimes come to you because you're the one that has the opening. When was the last time you had your teeth cleaned? My mouth is sore, my gums hurt, they're bleeding. Let's get you in with the hygienist. Okay, so what you need to do is figure out where do you go from there. The use of antibiotics is controversial. Again, some dentists will automatically put patients on antibiotics. Some will, well, if you don't have a fever and you don't have lymphadenopathy, you don't need antibiotics. So again, if things don't resolve, that's when you need to go into further investigation. Necrotizing periodontitis or necrotizing ulcerative periodontitis is usually only seen today in immunocompromised patients, and that's with the HIV. It's characterized by gingival necrosis, rapid and extensive gingival attachment loss and bone loss, gingival recession, and sometimes that bone is even exposed. And that exposed bone, my friends, is very, very painful. There is nothing that is going to make your patient want to brush and take care of this area because it's going to bleed and it hurts. So they're not touching it. And this here is exposed bone and dead tissue. Where do you see this kind of decay? And you're going to see some of this coming through the clinic because your patient's going to finally be able to say, I'm ready to take care of my teeth.
Looks like rampant caries.
I'm sorry?
It looks like rampant caries.
That's rampant, yes. And this is what we would call meth mouth. You oftentimes will see rampant decay in drug addicted or patients in recovery that used to be drug addicted. They're not taking care of their mouth. They're smoking whatever it is going in their mouth. And a lot of it has sweeteners in it. And they're drinking, they have a high sugared fermentable carbohydrate diet. And when you are not, when you're high, you tend to not take care of your teeth. So this is probably meth mouth up here. I don't know anything about this patient, but this here is necrotizing ulcerative periodontitis down here, which again is associated with HIV. So seeing what's on top here, I would associate that this is somebody that is an IV drug user. I'm just making that generalization. Don't know. Painful, painful, painful. Patient education. You've got your college kid coming in. Good oral hygiene is critical. Resume daily brushing and flossing after the acute phase is treated. For NUG, for the gingivitis, necrotizing gingivitis, oftentimes they cannot even touch their gums without them bleeding. So they have special tooth swabs that they can start with chlorhexidine. They have other things, ultra soft post-surgical toothbrushes to gently swab, drink fluids, avoid smoking, avoid spicy foods. A lot of this is common sense, but think about the patient that is coming in now with NUG. It's somebody under stress, young adult, malnourished. They're surviving on Coke or Pepsi and Doritos. It's right after finals. These are the students that we're seeing. Avoid eating or drinking for at least 30 minutes after rinsing with chlorhexidine. We're going to get into chlorhexidine, but chlorhexidine is a chemical that actually gets absorbed into the biofilm, into the bacteria, stays on the tissue. It has high substantivity, and you don't want to, and it tastes awful. And so you don't want to rinse off that flavoring agent as soon as you swish with it. You want it to stay in the mouth. Because it alters the taste and everything too. If metronidazole is prescribed, okay, for the gram-negative anaerobic bacteria, the patient must not intake any type of alcohol. We're going to get into that in a later chapter. You're also going to get into that as in pharmacology, metronidazole. So it's important that you stage your appointment. Sometimes you're not even able to start cleaning the patient when they come in, and all you're doing is educating them, but you're trying to get off as much as you can. You're going to give them palliative care, rinse with warm salt water. Here's some chlorhexidine. Here's some oxygenating agents. You're going to be doing this, okay? Then you start introducing the debridement as the patient can tolerate. Oftentimes, they will require some sort of topical or local anesthesia, but you want to flush, debride, have the patient come in very frequently so you can debride all 4 quadrants, okay? You're trying to get that bacteria to change. 2-month periodontal maintenance. I've never seen that. The patients I've seen with NUG have come in during college break, and you send them off and then they're back at college again. You're not going to see them until the next semester. But you've got your NUG and your NUP, which are considered ulcerative inflammatory periodontal diseases, but the new classification has taken that ulcerative out. So it's NG, necrotizing gingivitis, and NP, necrotizing periodontitis. So for the gingivitis, necrotizing ulcerative gingivitis, pain, bleeding, papillary necrosis. It only involves the gingival unit versus necrotizing periodontitis, you have attachment loss. P. intermedia and spirochetes are associated with the necrotizing gingivitis. P. intermedia, spirochetes, you got to know that. When the patient comes in, they're in a lot of pain. So you try and give them palliative treatment first, get them out of pain, and then you can start the debridement. So depressed PMN function is suppressed in patients with necrotizing gingivitis. That may be the first sign of HIV infection. Okay. So the correct answer is really A, but you were close. Thank you, Pam, for trying. Which of the following diseases must be differentiated when a patient presents with what you think is NUG? What have we talked about?
B.
B. Okay, guess what, folks? I'm only 6 minutes over. Any questions?
Yes, Miss D, I just have a quick question.
Oh God, you always have a question.
Yes, because I love question.
I love it.
Okay, so for the mucogingiva defect, so it could be considered NUC or NUP.
It's not, it wouldn't be considered any of them if it's just a mucogingival defect because of recession or a frenum pull.
Okay.
But if the attachment has been lost because of bone loss, gingival loss and bone loss, then it's periodontitis versus gingivitis. So it all depends on if bone is attached, but a mucogingival defect by itself has nothing to do with necrotizing. Those are
Okay, thank you.
two different things.
Yeah, because it's kind of looks similar to me when I saw the pictures that you posted. So
Yes, they look, yes, but a mucogingival defect is a description of what you're finding. And that's usually from toothbrush recession, toothbrush abrasion, frenum pull, something other than the disease process.
okay, all right. Thank you, Misty.
Mm-hmm. Any other questions? Okay, go out and enjoy the snowstorm before your next lecture.
Thank you.
Bye.